despite the number of times that we've covered this and discussed coding and billing for multiple kidney stones and ureteral stones, it seems like there's always confusion. And it makes sense because the rules keep changing all the time, even though we continue to do the same things over and over. So I'm very fortunate to have Mark Painter, managing partner of PRS Consulting today, to again discuss coding for stones. He has written multiple articles, also known as the guru when it comes to urology, coding, and billing. So welcome, Mark. Thank you so much for coming on at such early hour, 7 a.m. on a Sunday morning.
Thanks, John. It's glad to join you again. This is always a fun topic, and yes, I've written many articles, and unfortunately, not all of them have been the same, as the rules have changed over the years. So it is confusing.
You bet. So before we begin, I want to encourage those of you who are joining us live to ask your questions in the comments, and I will ask them to send them over to Mark so that we can answer them for you. But for today's purposes, we're going to be talking about kidney, ureteral stones, and possibly bladder stone, and how to code for treatment of these stones when we are in the operating room doing procedures, or for those of you who are coders and billers, how do you code and bill for these scenarios with your doctors? So kidney stone obviously are stones in the kidney. Ureteral stones are stones in the ureter, the tube connecting the kidney and the bladder. And bladder stones are obviously stones in the bladder. And scenarios that we'll try to cover today are number one, stone in the kidney and ureter, and we treat it ureteroscopically. Stone in the bladder and kidney, and this was a question from Dr. Grotus, and we do it cystoscopically. And number three, multiple stones in the kidney and ureter, and treating it ureteroscopically and with shockwave lithotripsy. And number four, shockwave to the kidney stone and ureteral and ureteroscopy to the ureteral stone. Let's see if we can cover them all in a relatively quick fashion. Believe it or not, that's a lot of information to cover. So let's dive right into it. And once again, if you all have any questions, please feel free to jump in. So let's talk about stone in the kidney and the ureter and treating it ureteroscopically.
Okay. So as you know, you've got the 52353, right, which is ureteroscopy. Which is ureteroscopy with lithotripsy and a stent insertion at the end, which is the newest of the codes. So a lot of people, obviously as we've gone through this process and looking at the way that CMS has bundled them, the way that the private payers are taking a look at all of those things, we do have some issues. So the first thing that is very key on all this stuff, let's look at a couple of things, is that you're saying that we have a preoperative diagnosis, right? And what is our preoperative diagnosis for this one?
This will be stone in the kidney and a stone in the ureter, and we are.
Right. And that's what right. So our preoperative diagnosis is we have stones in two locations, and we've always talked about the fact that the kidney, the ureter, and the bladder are three different organ systems. And originally, we were looking at the possibility of using the ureteroscopy and treating each stone separately. But if you look at, and I don't know, John, can you bring up 52356?
Yeah. So what I'm doing right now is I'm pulling up the AUA coding today, and I'm going to pick the CPT section here. This is an amazing tool. So those of you who are not using it, let's see, 52356.
Yep.
And you can just pull that up and hit enter. In the meantime, I have actually a summary slide of all the codes, but 52356, we'll click on that. Yep, got it. Cystoscopy with ureteroscopy and or piloscopy with lithotripsy, including insertion of indwelling ureteral stent, such as a Gibbons or double J stent.
All right, so when we looked at that code, I mean, really you're talking about a couple of different things. And originally we had looked at, all right, if you basketed the stone in the ureter and then lasered the stone in a kidney and put in a stent, right, that you should be able to bill the 52356 and the 52352 with an XS modifier for that separate structure. The problem we run up against is, you'll notice right underneath the description there's a parenthetical note within CPT. And that parenthetical note in CPT says, do not report 52356 in conjunction with 52332 or 52353 when performed together on the same side.
Yep.
So essentially what they're telling you is, if you lasered both stones, you can't bill both of those together, and you can't bill the insertion of the stent, right? So essentially, if we basketed one and we lasered one, we're using two different techniques. It looks like we could bill both of those with the XS modifier. Now, we do have a couple of payers that have actually extended what CPT has said in the diagnostic description here, and are blocking the 52352 and the 52356 from being billed together. And of course, I guess we should put the other one, if we don't put the stent in at the end of the procedure, instead of the 52356, we would bill the 52353 and the 52352, right? So, because we didn't put the stent in.
52353, for those of you who are not familiar, I have the description on the screen. It's basically ureteroscopy with laser lithotripsy. And if you read the description, it says ureteral catheterization is included. Ureteral catheterization is different than insertion of ureteral stent. So, Mark, can you explain that a little bit?
Yeah, sure. So a stent, and a lot of things that we call stents aren't always stents too. That's another problem that we always run up against. But the ureteral catheterization of actually the process of going up and shooting in some dye or putting something in temporarily to actually access the stone or run your glide wires or put your dyes in, that's part of the procedure. That's part of locating the stone and everything that you do relative to taking care of that problem. As opposed to a stent, which the Gibbons or the double J is usually a double pigtail or something that stays in place over time, and you leave it after the procedure so that the kidney can drain. So the leave behind is the stent, whereas the catheter usually actually comes, and it usually only runs from the bladder to the kidney or the kidney to the bladder. So that's the kind of the differences that we see between the catheter, which is A, temporary, and B, usually used during the procedure for access or visualization, versus the stent, which is left behind and is more for supporting the ureter. And so in case it's been inflamed, or you're trying to get the stone out a little bit easier, the stone fragments out for the patient.
You can go down so many rabbit holes with this. When you say, okay, so here, what about this? An OBGYN smartly asks a urologist to place double J, or not double J, but stents, lighted stents into the ureters to assist her with a hysterectomy.
Right.
Is that an indwelling stent because it is staying in, or is that a ureteral catheterization? I love this question.
So we would count those and have, as we've gone through this, as a temporary situation. You're only putting those stents in, and let's call them stents, but you're only putting them in temporarily for during the procedure itself. So that would be coded at a 52005 instead of the 52332. So it is in the long run. I think the easier split between the two is, how long are you leaving them in? If you're putting them in and they're going to stay for more than a day, then you go with a 52332. If it's really procedural based or during the procedure, you're using it's a catheter.
Got it. That makes sense. All right. I think stone in the kidney and the ureter, treating it ureteroscopically. Basically, the bottom line is, if you are lasering both, you cannot bill 52356 twice. But if you're lasering,
or 52353 and 52356, right? Yep.
But if you are doing a laser lithotripsy and stent placement for the stone in the kidney, but then you're doing a stone manipulation in the ureter, then you can build 356 and I think 352 at the same session during the same encounter, and using an XS modifier for Medicare. Now, we are, just to be clear, we are talking about Medicare in today's discussion. Private payers are going to vary, so you're going to have to pick your battles there and play their games.
Yep, you are, and a 59 modifier, which is the alternative to the X modifiers, is the CPT equivalent, and you can certainly play that game. And I can tell you that we have a few payers out there that will trial denial, and Medicare may be one of them, that even though you bill it correctly, the 52356 and the 52352 with the XS for Medicare or the 59, they'll actually come back sometimes and pull your notes to see if, in fact, and this is why I started this asking you to make sure we had the preoperative diagnosis, is if in fact it's a fragment that you basket after you've lasered the stone, then that's not separately billable, because you're actually cleaning up from your procedure of the laser. So you've got to have that diagnosis correct in the beginning, and make sure your claim has the N20.2 or the N20.1 and the N20.0 on the two different procedures.
Man, you can go down so many rabbit holes. Okay.
Yeah.
All right. So that or we'll just stay with that. Because I was going to say, that's what you said is very clear. Treat the stone if there's only one stone preoperatively in the kidney, and if a fragment were to go down the ureter, you cannot bill a separate code for the stone fragment that went down the ureter. But I'm thinking of a scenario where if you were to do a shockwave, in an unlikely event that you do a shockwave lithotripsy of a kidney stone and a fragment were to go down to the distal ureter, somehow you are able to track that. I don't know how you would be able to do it, but say you did, and then you go up with a ureteroscope to manipulate the stone and remove the stones. So it would be shockwave lithotripsy. So the pre-op diagnosis will be kidney stone, and you do a shockwave lithotripsy, and now you have a stone in the kidney that you treated, but then a fragment went down the ureter, and then you take a ureteroscope to remove the stone without putting a stent.
So, yeah, you did, Tim. But I haven't seen that one happen before. Usually that shows up later, right? But if it were, it is a separate approach with the 52352 to grab it. Technically, it's a complication of the surgery. So you really shouldn't deal with those. But the ability to actually report it and potentially get paid for it is there with a 59 modifier, an excess, maybe but intraoperative complications treated by the same surgeon are part of the procedure package. So you really shouldn't do it. And even though it would probably slide through the coding edits. Yeah.
So there's so many things that you can think of, but all right, let's move on. And once again, for those of you who are watching this live, please feel free to ask any questions that you may have in the comments. I will make sure that I pass those along to Mark so that we can get your questions answered. Okay, let's move on to scenario number 2. We have this came from Dr. Grotus. Stone in the bladder and the kidney, and you take care of it cystoscopically / ureteroscopically. So, for instance, you preoperative diagnosis of a bladder stone and preoperative diagnosis of a kidney stone. You go into the bladder and you do a cystolithopaxy of a small stone, and then you go up into the kidney and then you treat the stone ureteroscopically with laser, and then you put up a stent at the end of the procedure.
Okay, so you should be able to bill for those separately. So you would bill the 52356 for your kidney stone and the stent, just like we talked about for the last scenario. And then you would use the lethallopaxy code for the bladder stone, which would be the simple, the 52315. So would be, I think, the right coding there.
Oh, that was an easy one.
Well, let's make sure I got that. Let's make sure that 52315 was right.
Okay, I just pulled up AUA coding today. 52315. I'm just entering that into the search field, and
Yeah,
it is thinking. It is thinking. 52315.
And that's why I was double checking. It was a 52317 is the lethallopaxy.
Ah, very good. 52317. Very good.
Yeah, sorry.
Yeah,
about
can't
that.
expect you to memorize the thousands of codes, right?
Well, if I'm getting older, unfortunately.
All right, 52317. Lithopaxy. Lethallopaxy. Crushing or fragmentation of calculus by any means in the bladder, and removal of the fragments, simple or small, for stones that are less than 2.5 centimeters. So now here's the other thing. When it comes to stones and treating them, say you have a contiguous stone that is smaller than 2.5 centimeters, or often you have a bunch of little stones in aggregate greater than 3 centimeters. What is the kosher way to treat or code this in the eyes of Medicare? Or is this treated kind of like a bladder tumor where you just count the one largest stone or largest tumor?
This one doesn't read the same. Remember, the tumors are stone or tumors, and you code based on the largest tumor. We've had that full discussion over. But this is, in the end, it is talking about, crushing of calculus by many and removal of fragments of a simple or small. So you've got simple and small. So in the end, it's if you've got multiple stones, you might actually move up to the next code that I think is a 52318, which is complex or large. And so you've got a little bit of leeway there to say that multiple stones was complex versus simple. So we don't have the same added up type of thing. It's not just the large, it's simple or small and complicated or large. So you'd have to, if you diagnose it as complicated because multiple stones, you could use the 1.8. So
if you have, basically the bottom line is if you have a bunch of stones that in aggregate count up to greater than 2.5 centimeters, you can bill for the large or complicated, which is 52318. All right, went down that rabbit hole.
Yep, and then and by the way, it doesn't have to add up to greater than 2.5. It just has to be complicated because
or complicated.
You're not an A. Yeah, right.
You got it.
And we still need to use, by the way, the XS or the 59 modifier when we bill in the 52356. Was the one piece that I wanted to make sure we added in.
Yes, for the scenario number 2, when you're treating the stone in the bladder and the kidney, you do the cystolithopaxy and then the ureteroscopy with laser lithotripsy and stent placement. Be sure to use the modifier XS. And again, we are talking about Medicare, so private payers different. Okay, let's talk about scenario number 3, a little bit more complicated. We have now multiple stones in the kidney and the ureter, and number 1, let's treat it ureteroscopically. So let's say you have a stone in the upper pole, preoperative diagnosis, kidney stone or kidney stones. You have stones in the upper pole and you have stones in the lower pole, and you treat it ureteroscopically with laser lithotripsy, and you put up a stent at the end of the procedure because you use an access sheath and you have to drive the scope up and down multiple times, and you did a bunch of lasering and all that stuff.
Yeah, I wish I had a better answer for you on this one because, the bottom line is it's treatment of stones. And so you can't bill it multiple times, nor can you, we already know you can't bill the 52353 without the stent, and you can only put up one stent in most patients, by the way. Occasionally you got the duplicate ureter, which messes everything up. But generally, you're the only way to actually report and get paid for the work that you do there is a modifier 22 and excellent supporting documentation, hard work, and a little luck.
Well, Medicare is fairly straightforward, but when it comes to private payers, you may have to play their game. But yes, that's exactly what I do too. Whenever I have to deal with multiple stones in the kidney, I do the best you can, try to clear everything, and clearly document in the operative report, and actually in the findings section of the operative report. So what I do is I actually will document the amount of energy that was used. For instance, I can say I use 41 kilojoules of energy to break up so many stones, or I will say this procedure took greater than 50% of the effort that would normally be used for a 52356 for a ureteroscopy with laser lithotripsy. Or I will say this procedure took an additional 30 minutes, but 30 minutes to the high school educated auditor at an insurance company, sometimes they may not understand what does 30 minutes mean? Does that mean 10%? So you try to make it as simple as possible for these auditors to say, okay, now I understand he expended extra effort and energy, number one, and number two, how much effort or energy. You're making it easy for the person reading your note to appropriately pay you.
Yeah, that's a good way to do it, right? You do give them relative time and clinical reasons for that extra time is kind of the base piece of that. And so if you could get to took me twice as long or took me 1.5 times as long, that give them something to actually pay you or understand what they need to pay you relative to what they normally do. So.
And I will throw this in here. The consequences are not just to your professional fees, but it may impact on your surgery center's fees. So if you are doing this at a surgery center, sometimes the payment from private payers may vary greatly when you dictate appropriately. So if you are a partner in one of the centers, it makes a big difference to in that regard as well.
Yeah. Yep. You got to pay attention to the documentation every single time. That's for sure.
I think the astute coder and biller will jump in right away and tell you that it will always drop the paper. It will always have to be reviewed whenever you use a modifier 22. So be prepared for that. And sometimes if you know your doctor is coding a modifier 22, you may just want to straight up submit the additional documentation, attach it to your initial claim so that you can get paid in a timely fashion.
Yep. If you can, if the payer will accept it, go for it. We definitely have a few that they require the denial first and then you go back. But if you can submit it up front, the operative note, do it. There's a way to pen it in the clearinghouse in most clearinghouses, for sure. But know your payers and know the game.
Okay, multiple stones. We took care of the stones in the kidney and multiple stones in the ureter. I would say it's the same thing. Depending on what you do, 52352 or 52356, depending on what you do, with a modifier 22,
Correct.
With appropriate documentation.
That's exactly right. And do remember, maybe we ought to talk about this just a little bit. If you were treating the stones in the ureter and you put a stent in, and you treated the stones in the ureter by just extraction, you didn't laser them. You can bill the 52352 and the 52332, and in our complex case, the 22 modifier would go on the 52352. Not on the 332. So make sure you put it in the right spot too.
Yep, and I got it on the screen. 52352 is basically ureteroscopy with manipulation of the stone, basically removing the stone in common parlance. And 52332 is simply putting up a stent into the urinary system. So just so that not everyone's a coder, so I want to make sure we educate everybody in the best way possible. Okay, yeah. So we talked about multiple stones in the kidney, ureter, treating using ureteroscopy. What about shockwave lithotripsy of multiple stones? They say you do a stone in the kidney. Preoperative diagnosis will be kidney stone and a ureterostone, and you use shockwave lithotripsy to treat the ureterostone and the kidney stone in the same session.
Yeah, so this has been a tough one to do. Ultimately we do have again, to fall back on the fact that the ureter and the kidney are separate structures. So we've tried with a few folks with the 50590, which is your extracorporeal shockwave lithotripsy code, to bill for each structure that we did, that a shock was to which a shock was delivered. But I can tell you that the code itself is not very specific to a stone or to a location. It really is a sided code, meaning you can bill it bilaterally, but it is difficult to actually get that paid twice on the same side because the patient is often repositioned as they do the 50590. So even though there is a pathway to potentially report those things, the reality is the majority of times when you look at the 50590, you're probably on the same side, stuck in the same boat with multiple stones in the kidney, and using a 22 modifier as your best pathway to payment. That most payers will only pay twice for 50590, and that is if you use it on both sides on the same day.
Got it. Makes sense. And the CPD description does not specify location, like site.
Right.
It just says lithotripsy extracorporeal shockwave, and that's it.
Yeah, that's it.
And we'll have to adjust the lay description. The patient typically is not prone in a vat of liquid. That was back in the 1980s when the HM3 first came to the United States. Yeah. But that's no longer the case. Patients typically supine and not in a vat of liquid. So that was back in the old days. Okay, that's
classic. We'll have to talk to the guys who give us the lay descriptions on those things.
Yeah. The new coder may be confused by reading that description. Okay, I think we covered multiple stones in the kidney and ureter, treating it with ureteroscopy and shockwave lithotripsy. And once again, those of you who are watching, and I know there are a few of you who are watching, if you have any questions, please feel free to leave them in the comments so that we can answer them, because this is really for you. And I'm really appreciative of Mark taking his Sunday to go over this with all of us so that we can be educated, so we're not leaving money on the table. And speaking of leaving money on the table, the PRS network is hosting a bunch of E&M workshops. There are 4 of them coming up. As those of you who are astute in the urology space, E&M coding changes are coming in January of 2021. So big changes. You want to make sure that you're not leaving any money on the table, because urology is kind of unique. Not only do we do surgeries, we also see a lot of patients in the office or via telemedicine. As the E&M rules change, it can impact hugely on your bottom line, whether you are by yourself or you have a bunch of APPs. So make sure you don't miss out on those opportunities. I will leave the E&M workshop link in the video description, so you are not missing out on those opportunities. Okay, let's go on to scenario number 4, shockwave lithotripsy to kidney stone and ureteroscopy to the ureter stone. I think we covered that.
We did, as long as we weren't, dealing with I think we covered a little bit with the same stone, but with different stones. If you treated one ESWL and, again, you had a separate diagnosis and you treated another stone with the laser, we could look at that, but on the same stone.
Got it. So that's clarified. So pre-op diagnosis for this scenario number 4 will be kidney stone, and pre-op diagnosis will be ureter stone as well. So it will be kidney stone and ureter stone. And the plan is to initially, under anesthesia, clear the stone in the ureter using laser lithotripsy, and you plan to put up a stent, or you put up a stent at that session right there. And during the same session, you position the patient and use shockwave lithotripsy to treat a stone in the kidney. So how do we approach that?
So in that case, you've got 2 different stones, 2 different locations. That would be the 50590 and then the 52356 with the excess modifier. So again, the laser treatment of stone and ureter is the one that is the lesser of the two, if you will, in the eyes of the bundling matrix. So you want to make sure you put it on the right code, and we probably should double check that because that flips around on occasion.
Great. So speaking of the bundling matrix, I'm going to show the screen that has the AUA coding today. I'm going to go to the left-hand column, and under tools, there's something called the bundling matrix. And let's just put in 52356, 56, and 50590. And you can put them in any order. The date of surgery is today, 8/30/2020. And we want to sort the results by either facility or non-facility. For those of you who are not familiar, for facility, you can think of it as a surgery center or the hospital, and non-facility is basically in your office. So if you think of it simplistically like that, that'll keep you out of trouble. And you click on Analyze Codes, it spits out a screen. So if you don't mind, Mark, go ahead and explain this for us.
Yeah, and so this is one of those interesting cases overall. So, and I'm going to pull it up just so I'm looking at the same thing. And we're looking at it in the facility setting because this is probably going to be in a facility.
Oh, I'm sorry. I clicked the wrong thing. There we go. Facility. There we go.
Yeah. So you can see that the 50590 comes up as the first code. It is the higher valued procedure code. And then the 52356 comes up as the lesser valued code. But if you read in that yellow box, it says 50590 excludes 52356. Now this is a little different than includes or included in, because these two codes are considered to be mutually exclusive. So a lot of times, you have codes that actually end up treating or the same results or the same thing. You can do it two different ways. They put those in as mutually exclusive, and that's why it says excludes instead of includes, which is a different way to look at the bundling matrix. Now, when a code is excluded, you actually should put the excess modifier on the first code. In this particular case, it would be the 50590 that gets the excess, not the 52356. Because if they're put in without modifiers, the mutually exclusive category of codes, actually the instructions in the computer are to pay the lesser valued of the codes. So the code that's at risk of denial is 50590, even though it is the higher valued code here. It's the code that needs the excess modifier. So I misspoke the first time through, which is why I'm glad we put this back into the bundling matrix to remember. I knew that we had a problem, but the bottom line is we got to know where our problem is and which code's at risk.
So humans are prone to errors, and that's why you need the bundling matrix, because even the expert sometimes misspeaks. And the bundling matrix is a computer. It is just going to tell you the right answer. So you should definitely consider getting the AUA coding today. It is awesome. I mean, I look up codes all the time, and I look at the bundling matrix and things like that, even though I don't do the coding and billing. However, leaving money on the table is something I try not to do.
Amen. It helps you build your documentation the right way so you can support your billers and coders. Is really that's that for a physician and for the coders out there. Going back and showing your physicians why they need to document the way they document, and having that, as you know, that extra backup, because it's oftentimes that that we need a little bit extra to talk to the physicians to give them that little push over the edge.
And I know I am not typical in my practice. When going back to the modifier 22, in my practice, we don't even need to submit any additional documentation. Just putting the modifier 22 and doing a little explainer in, I think, box 19 of CMS 1500, we automatically get paid an extra amount whenever we use the modifier 22. I think
you built a reputation up with those guys as actually doing the right thing all the time and knowing what you're doing, and they know that messing with you costs them more money than it's worth.
Correct. And I think Art Lurvy was the one who said this, and I was like, oh yeah, it makes sense, because Art Lurvy is one of the medical directors for Noridian, right?
Right.
Dr. Lurvy.
Yep.
During the Western section of the AUA, he said, you know what? It costs us money whenever we have to ask for additional information. So Noridian is paid a set amount of money. Their goal is not to deny claims if they're clean, because it costs them more to reprocess claims.
Yep.
So you have to kind of think about it that way as well, which is interesting.
Yeah. But then you got the other side of the coin is that, about 50% of every claim that gets pushed back to the physician is accepted for exactly to be as being correct. So if you're not willing to go the extra mile to fight that 22, you're going to end up on the other side of always getting denied. So if you're going to use it and follow it up.
Yep. Push it all the way through. Okay. Dr. Hayeri said, what about, here's the scenario. What about if you have a calcified retained stent? Say another urologist puts in a stent and the patient was advised to follow up, but of course you get these non-compliant patients. You send them letters and certified letters and call them and say, hey, the stent cannot stay inside you forever. They ignore it. Now they come into the ER with a calcified retained stent, and you can't just pull it out because you're going to avulse the ureter. So Dr. Hayeri says, what if you have one of these stents that the proximal part is treated with shockwave lithotripsy, and then the distal end, you use laser lithotripsy, stone manipulation, and put up a fresh stent at the very end of the procedure?
Well, I'm thinking right now 22 for whatever you're going to put in there, because it's going to be complicated. But it sounds like you've got a 52356, right, for the laser treatment of the stone-like material, if you will. That's, regardless of where it is, crusted around the stent or floating around in the kidney, it's still a stone's a stone, right? On the whole thing. So a 52356, and if you do the manipulation elsewhere, you got a little bit of a different issue here. It's probably not. I'm assuming we don't have it in the ureter. We're stuck on the bottom end at the bladder. Is the other end? I'd have to know exactly where. As we went through this, I'm thinking it was on both ends.
Correct. He said the proximal part is treated with shockwave lithotripsy and the distal end with a laser. So let's just assume the proximal end is in the renal pelvis, and the distal end is, I guess, you can consider it bladder, or it could be the distal ureter. So
then you would have maybe the 52318 for a complicated treatment of a bladder stone, and then a 52356 for the kidney, and inserting the next one, and then put your 22 where on the 52356, because we already used the complicated end for the bladder. So that would be one way to look at it, and probably the best way to look at it. The other one would be 52315, right? Would be another way to potentially look at that, which is the complicated removal of foreign body in the bladder. So you might want to, that would be the other end, that you, instead of a 52310, which is what we would use normally for cysto stent removal. So maybe you do a 52315 and a 52356 as a combination there, and you're going to have to use an excess for that particular combination as well. So I think you got a little bit of movement around, but after thinking about it, I would actually go. Let's say the best would be 52356 and 52315. With a 22 on the 52356 and the excess on the 52315.
So 52315.
Right.
Okay, got it.
And the 52356.
Okay. 52356. 315, and you want to use
Yeah, that's right. All right. So we check the bundling matrix on this, and actually 52315 is unbundling never allowed.
Okay.
So even though that may be right from the CPT side, we'd probably be better off with 52318 for treatment of the bladder end, because we're crushing up the stones down there. So if we use the crushing the lethalopexy in the bladder and then the laser for the other end, we'd actually have a better chance of getting paid. And we're actually doing that. And unfortunately, we're stuck with the stent exchange rule, right? That you can't charge for removal and reinsertion on the same visit. You can only charge the insertion.
Correct. Correct.
So following that up, let's switch that over to 52356 and 52318.
Okay, so I'm showing the bundling matrix with 52318 and 52356 on the screen here, and 52318 should be listed first, followed by 52356. And what modifiers specifically would you say that we need to use for 52318 for this management of the complex stone in the bladder?
So we would use the XS.
Got it. Extra, yep, different site. Okay. Yep. And then you said 50, and then what?
Because it's a different structure. Right?
Got it. And no modifier for the 52356.
Well, I mean, at 22, if you've got the right.
The scenario's right.
Yep, if you got the scenario right. And then in the facility side here, the 52356, even though you've got them listed that way, but look at the verbiage in there, modifier required. 52356 includes 52318, right? So the 52318 is the code at risk. It's the one that actually gets the excess.
318.
Yep, 318.
So it's, it's pretty nuanced. I mean, come on, we're going through this in a live situation, and it's nuanced, and it's confusing, and it's complicated, and that's why we need this bundling matrix, because you think but then once you put it in, the computer is going to tell you, okay, well, according to the rules, this is what you need to do, and then this is how you can unbundle things so that you can get appropriately paid, because the work has already been done. Now we just have to play this stupid game and try to get reimbursed. Yep,
and I suppose this is a good time to mention the Mark Painter general rule of thumb, which is if it's a rule from Medicare and it's logical, that's probably an accident. So unfortunately, you can't just rely on logic to solve these problems. You got to look at the actual rules. So
yeah, and then that includes not just Medicare. There's NCCI that you have to worry about, National Correct Coding Initiative, and then you have to worry about CPT. Sometimes Medicare follows NCCI, but not really CPT. Sometimes Medicare has its own rules, and it doesn't follow anything.
So, yep, it keeps us all entertained at the very least.
Certainly. Well, the arguments are not as heated as the current political arguments, but it certainly can get very exciting.
Yeah, very true.
Okay, Karen's asked if we're not sending documentation with the modifier 22, what wording are you using in box 19? When I ask my biller, she simply puts in X number of percentage, basically what I put in the finding section of my op note. X number of minutes more than normal, X percentage more than the typical surgery. Number of shocks, or the amount of energy that I use for the laser. So now, as I've become more sophisticated, I will try to put in all that, the percentage, the amount of time, and also the laser, the energy that was used, and that generally gets it through. So
yeah, so she's probably your coder and your biller in those things is probably trying to meet really that 22 issues, like answer those two questions. What was the clinical difference and what was the time difference? So give them those two things and in as few words as possible. That's what you're shooting for in box 19, I'll bet.
All right. Well, I think we've answered all of the questions. Seeing no more, I think we are going to end this so that you can go enjoy your Sunday. And thank you so much, Mark, for coming on again and helping us all.
You're welcome, John, and we'll call it done for now until they change the answers again. How about that?
Yeah, no kidding. Hey, have a great weekend. Hey, for those of you who are interested in the PRS Network E&M coding workshop or the AUA coding today, I will put them both in the video description. So feel free to click on those, learn more about them, and learn everything you can in this crazy world of coding and billing so that you're not leaving any money on the table. Until then, have a good day. Bye-bye.